Kezia Putri. She is a board-certified music therapist with a master's of music therapy degree from Wilfred University, Canada. She is currently practicing in Jakarta, Indonesia, and is a coordinator of the music therapy course in University Putra Harapan, the Conservatory of Music. She is also the president of the Indonesian Music Therapy Association from 2023 to 26, and a member of the Research and Ethics Committee of World Federation of Music Therapy. Areas of interest includes clinical improvisation, receptive methods in music therapy, mental health issues, PTSD, post-traumatic stress disorders, geriatric issues with elderly, and the use of traditional Indonesian music resources and music therapy clinical work. She's also interested in music therapy advocacy and global networking. Today, she'll be talking about music therapy in the Indonesian perspective. Now, I'll stop sharing so we can have her start a session. Now, you on, Kezia.
Thank you, Bhuvana, and hello, everyone. Good afternoon. Thank you so much for having me. My name is Kezia, and I will share my screen just a moment. Oops. Okay, can anyone see my screen now? Yep, okay, great. Yeah, so I am an Indonesian. I currently live and work in Jakarta, Indonesia. A little bit about me. I got my Bachelor of Art in Music Therapy concentration at Universitas Pelita Harapan in 2016, and then my master's in music therapy from Wilfrid Laurier University, Canada in 2019. I am certified by the Certification Board of Music Therapists, USA, and also I'm an accredited member of the Canadian Association of Music Therapists. I'm currently a full-time lecturer at Universitas Pelita Harapan, and I'm a program coordinator for music therapy there as well. So my full-time work right now include teaching, supervising, and doing research, administrative work, advocacy work. It's not as much practicing as I want, but I believe that what I'm currently doing is also for the advancement of music therapy in Indonesia, and I enjoy every day of it. So I am going to talk more about the advocacy side and the training and education side of music therapy work in Indonesia. Before that, I will talk a little bit about the background of Indonesia. First of all, I am so sorry, pardon me if my voice sound a bit groggy. I am currently recovering from COVID. I got COVID 2 weeks ago, and as you might know, some of the symptoms might linger. I still have stuffy nose and sore throat, so bear with me. Yeah, so here you can see Indonesia. Indonesia is this area, this yellow area here. We are very close to Malaysia, and we are very close to Singapore as well. We are located in Southeast Asia, of course. We have thousands of islands, therefore it is called an archipelago. And if you can see here, because we are consisting of islands, each island is separated by sea. Connectivity has always been an issue in Indonesia. I mean, both physically and internet connectivity wise. There are 17,500, at least 1,700 islands in Indonesia, and only 16,000 of them are already claimed in the UN. And because we are consisting of islands, automatically we have, lots of ethnic groups and language. There are at least 829 known language in Indonesia. I'm sure I've heard that in India you have quite a lot of language as well. So even though we have at least 829 language in Indonesia, we have one national language called Bahasa Indonesia. Although not all Indonesians spoke Bahasa Indonesia, for example, older people, people that lives in a more remote area, they don't really speak Bahasa Indonesia. And we have around 478 ethnic groups in Indonesia. And each of them can be distinctly different. So I would say people that come from Sumatra are normally very different in terms of values and characteristics compared to people in Java Island. Or people from the Papua or Maluku Island can look very different from people who lives in Kalimantan Island. It can be both an advantage and also a big challenge. On one side, it's great that we have, a variety of this culture. We are rich in terms of culture, but also having a very different culture can mean that it is very difficult to unify us as a country as well. So yeah. I will also convey a little bit of the history of music therapy in Indonesia. Music therapy in Indonesia was first introduced through Universitas Pelita Harapan in 2007. It is one of the 7 concentrations within the music program at the Conservatory of Music. So it's not even a study program, it is a concentrations. So we have an undergraduate degree in the Faculty of Art. This undergraduate degree is from the study program of music. And underneath that music study program, we have 7 concentration: composition, music education, and pop, jazz performance, sound design, music production, music management, and one of them is music therapy. So ever since 2007, that means it's about 15, 16 years ago, we have at least 50 alumni. This is not a great number. We should have had more than that, but the truth is, the fact is, student intake in Universitas Pelita Harapan for music therapy program has been really fluctuating. One year we can have 11 students, and then another year we could have just 1 student per cohort. I was in 2012. I am an alumni. In 2012, I was the only music therapy student. So it's always fluctuating. It's not great. And even if we have 50 alumni at least, most of them don't end up continuing practicing music therapy. So that's another issue. I think mostly that's because music therapy in Indonesia is not yet recognized, especially back then. It's very hard to look for jobs, very hard to promote yourself. And, with bachelor graduate in music therapy, I don't know about India, but at least in Indonesia, a lot of them have issues with confidence. Going out of school and then having to promote yourself, having to advocate for your work in a big institution like hospitals or schools, it can be very intimidating. Talking to doctors, talking to psychologists, that can be very intimidating for them. So not all of them want to, pursue that. They tend to choose something that is, easier. They tend to depend on other people to give them job. So a lot of them continue to be music educators. Some even become a music performer. Some continue on doing something else like business. Only a few continue on in becoming music therapists. We do have alumni of other overseas university, but that's not a lot. If I'm not mistaken, we have around five or six of them, and only a few are master's graduate. So then fast forward to 10 years later, 2017, the first music therapy department in a hospital medical rehab unit was established. This is the first hospital in Indonesia to say yes to creating a music therapy department within one of their unit. And it is a full-time position. It's still around until today. My colleague Jessica did a really great job in building the program there. And even though she's no longer there, she's now getting her master's in the USA. It's still around. Someone else has taken her place, and it's still going strong. And because of this, other hospitals, other doctors, other healthcare professionals started looking into the program. And ever since this happened, demands for music therapy started growing in Indonesia. I've observed growth in demand since probably the year 2020, especially. However, the issue is that, like I said before, we don't have enough human resources to fulfill this demand. In fact, just last year, I just declined an offer by 3 different hospitals. One in Surabaya, one in Semarang, and one in Jakarta. They offered me to create a music therapy program in that hospital and wanted me to take on the role as a permanent music therapist, but that's not possible. Because the truth is not that I don't want to. It's not just that I don't want to leave Universitas Pelita Harapan. It's the truth is there is no one else that can take on the role of university lecturer. The government has their own regulation in terms of what credibility, what education you need to become a university lecturer, and there's not a lot of us left in Indonesia that can take on that role. So I offered that job, that offer to other music therapists, but unfortunately, all of them, their loads are really full, and they are not willing to relocate to a different town. Of course, it is a big decision. So unfortunately, we had to decline them. One of them said yes to online session, so we are still doing that right now, but the other two said no, because it makes sense, because it was a pilot program, and they require someone to be there full time. So yeah, it is not great. If we continue on like this, I don't think music therapy will be around any longer, because demands are not going to be there forever. It will be fluctuating as well. It will keep changing, and we need to be ready to answer those demands. So yeah. So identifying those issues, me and my colleague in Indonesia created a blueprint for the future of music therapy in Indonesia. So as we've seen before, the problem with Indonesia is connectivity and outreach. Connectivity meaning it's really difficult to, travel to different parts of Indonesia, and it's costly as well. And also, online session is not always the answer to that. Low number of human resources, and most of them are centered in Jakarta area. Outreach not that great. There are no music therapists available in other towns except for Jakarta. That's why we couldn't answer to that demand, the one that I mentioned earlier. And Another problem is that music therapy training program in Indonesia is expensive. There are not many scholarship available and seems exclusive. Currently, the only scholarship you could get to enter the music therapy training program in Universitas Pelita Harapan is a 50% discount of tuition. There is no full scholarship, and that can be really difficult for a lot of people in different town. Not many of us can afford education. So there needs to be change. And also another problem is there is only one music therapy undergraduate program in Indonesia, and we don't have master program yet. I've been contacted by a few people ever since I returned to Indonesia asking about how do we train in music therapy? How can I train in music therapy? And at the moment, by the time I answer, we only have undergraduate program in Indonesia, meaning if you want to be a music therapist, you need to go back to undergraduate program if you want to stay in Indonesia, or if you want to attain master, you need to go overseas. Answering them with that answer does not feel good to me. It feels like I said, it feels exclusive and it's not helpful. And the problem is that most of the people who are interested in studying music therapy are professionals, mature students. That is probably the reason why our student intake is always fluctuating, because we cannot depend on high school graduate to immediately want to pursue music therapy. Music therapy is not well known in Indonesia, so it makes sense that that's not their first choice. So they're reluctant because going back to school means that it's expensive, it's not flexible, they have to work, it's time consuming because it's a 4-year program. And, if we talk about bachelor students, what we have observed so far is that a lot of them are brilliant, a lot of them does not struggle with theory or courses, in-class courses, but a lot of them struggles when it comes to applying what they've learned to field work or practicum. And it's not because they don't know, they don't have the knowledge, it's not because they don't know what to do. It's mostly interpersonal skill and also work ethics, which is, apparently after a few conversation with other lecturers in the faculty and other faculty, also lecturers from other university, this is a trend. Post-pandemic, post-COVID, during COVID, they have to learn via screen, they have to learn online, they don't see many people. This is the result. They don't have that interpersonal skill that we need in music therapy practice. So these are the issue, and we came up with a few solutions that might help answer the challenge. Number one is renovating the existing music therapy curriculum and syllabus. Like I said, a lot of them struggles with interpersonal skill, just approaching people, working together, advocating. A lot of them struggle with work ethics. So that's what we need to train them as well, not just knowledge or skills. Musical or clinical skills. How do we train interpersonal skill and good work ethics in Universitas Pelita Harapan? We apply these points in almost all courses. So it's not just music therapy courses, but we have had meetings discussing about this in faculty meetings and requiring the head of the department to start thinking about incorporating interpersonal skills in all courses, meaning they can have, for example, history of music class, and we are requiring them to interview experts in history of music. And we are requiring them to work with someone else from other than, musician, to create infographic, perhaps, or to create education through social media. We have a course, a mandatory course in Universitas Pelita Harapan, specifically to train music students to understand marketing and management in art profession. And of course, within the music therapy courses itself, I constantly create assignments that require them to work collaboratively with other students, that requires them to meet with people, that requires them to go out there and observe how they work in an institution. And I mean, we have this thing that's called ChatGPT anyway right now, the AI-based application. And I don't think written essay reviewing papers is a great way to assess student, because they have that nowadays. They can just type, how do I explain what clinical or therapeutic relationship is in music therapy, and ChatGPT can just generate a 1,000-word answer based on that questions. So we need them to go out there, do all these interaction. We need them to brainstorm real issues. We need them to observe how things work out there in the field, so that when they go out and when they graduate from this program, they're not shocked to see, they're not surprised to see that, oh, this looks so different than what we have in class, because that's always been the problem. And it will also help them with their confidence, because we sort of, push them to go out there before they graduate, so they are used to it. The thing about confidence is that we want them to get used to the environment. So yeah, other than training interpersonal skill, we want also to provide them with comprehensive experience, including encouraging interdepartmental mindset. One of my course, music therapy technique course, I have my students for their final assignment. A part of their final assignment is they have to create a concert for seniors, meaning they have to work with students from performance concentration, sound design, and also music management students to create this concert. Solution number 2 is designing a separate program that is more accessible, flexible, and economical, of course, without diminishing the program's credibility. So in Universitas Pelita Harapan, we are currently in the process of designing a brand new music therapy learning program that we call a module-based music therapy training. It is going to be a self-paced hybrid learning module. Our objective is to provide a more accessible, flexible, and economical training program targeted for mature students. So remember earlier, I talked about how a lot of the people that are interested in getting into the music therapy training are mature students, professionals. They have got their degree and they have their experience in the field. This is what we are trying to do to answer those demands. because I don't want to be answering to them with, oh, you have to go back to undergraduate degree, you have no choice, otherwise you can go overseas to get your master's. That's not an answer to me. That's not helpful. So with this program, I can now answer to them, oh, we got this program. All you have to do is complete all these 16 modules. 60% of it will be online asynchronous, meaning it's self-paced, it's recorded, it's self-paced, they can do it anywhere and anytime they want. Still, pardon me, I believe that music therapy, it's impossible for us to teach music therapy fully online. You still need to do something on site, especially when it comes to music therapy techniques. So 10% of the portion of this module will be in an on-site workshop, 1 week workshop style. There will be 3 modules, 3 techniques, music therapy techniques module that will apply this method. So for each module, they have 1 week on-site workshop. So that means 3 weeks plus 30% supervised fieldwork course. This is their practicum. Of course, you need practicum. Plus, when you finish all these 16 modules, all you have to do is pass the final exam. This is a way more accessible, way more flexible way of learning music therapy. And, looking at what's going on currently, I think this will be the trend of education going forward. People need things to be flexible. I'm working, I need money, I need to be able to do this at my own pace. So it will be designed, like I said, we are not going to diminish the credibility of the program. It will be designed by 3 international consultants, which is one of them is Dr. Indra Salvaraja, and at least 15 different contributors and lecturers from a variety of expertise and different geographical location. One of them is Ms. Buvana. I'm very honored to have you help me in this program. We will have 6 music therapists working on this program, contributing each depending on their expertise in the field. We will have a few psychologists working on the psychology modules and a few musicians, music lecturers working on the music module. So yeah, I hope this will be the answer to the challenge, one of the challenge. We are aiming to increase the number of music therapy practitioners in Indonesia. Yeah, I've mentioned earlier that we are in crisis of human resources. I believe that, it's not the first day of this symposium. You've probably heard more about the field, the work, and I believe it's similar everywhere you go. Music therapy, it's not just about you working with client. As music therapists, you cannot just constantly thinking about just working with clients. You have to do the advocating, you have to do the research, you have to think about associations. And those work, you cannot do it by yourself. You need teams, you need a lot of people investing their time in these works. So with only 10, 11 practitioners currently actively practicing in Indonesia, it's not enough to do all that work. We need more people, we need more manpower, brain power to do all these works. And it's not just about increasing the number of music therapy practitioners, it's also about the outreach. We want to have music therapy practitioners that's coming from different region of Indonesia, not just Jakarta and Tangerang area. I believe doing this, we are inviting different culture of Indonesia, and I believe it will make the identity of music therapy in Indonesia richer and more inclusive that way. it will shape the identity of music therapy practice in Indonesia, so that our view is not just the Western work of music therapy practice, because that's what's going on currently. I'm not saying that Western concept of music therapy is bad. It's just that it's better to have variation, right? Also, these modules, you don't have to take all 16 modules if you don't want to be music therapist. If you are an educator or a doctor or a psychologist, let's say, and you want to be able to use music in your daily work without being a music therapist, then you can just take a few of our modules a la carte style. So not only will increase the number of music therapy practitioners and do the outreach, but also it will provide insights for educators, clinicians, caregiver on how they can utilize music in their work or in daily life. Solution number 3 is national association. I realize this is not really education, but still very important. I believe that association and education needs to work in parallel. Because association is very important in terms of designing code of ethics, standard competencies, locating members, registration, etc. And solution number 4, I think this is the last one, is researching alternative for remote or online, no, this is the second last, or online sessions and wider outreach. Remote session will not stop post-pandemic. So the current issue with our media of remote session is that it doesn't feel the same as on-site session, right? You are doing session with video call, a platform that does not feel the same, and not all music therapy techniques can be applied to video calling platform. Plus, internet in Indonesia sucks. I don't know how it is in India, but it's really bad. Here, it's, you'll be playing something here and on the other end will be delayed. So that's an issue that's not reliable. And some clients need assistance. Not all of them can be independently, involved in online music therapy session. So one of the way that we are doing right now is training other professionals to use music to aid them in their work. One of the thing that I've done is working with that doctors in Semarang. We use receptive music activity to help reduce burnout symptoms in healthcare workers. And we create this online music program for them to be able to use it by themselves. And I'm currently working with one doctor in Sulawesi Selatan, South Sulawesi, in creating a remote group music therapy session for schizophrenic patients. The patient will be accompanied by doctors and nurses on site, while the music therapist will provide instructions and guide the session through video calling platforms. So we will be providing brief training for the professionals, but also be conducting and providing instruction on the day of the session. And then I've also done a few workshops and seminars in Central Java to introduce how music activities can be used by non-music therapists for therapeutic purpose. Some of them are teachers, educators, some of them are parents with special needs children. Some of them are music educators, doctors, nurses, therapists. And it was fun to, make music with them, provide some insights on how can they use music in their work, but also I'm gaining insight on how they work in their respective profession. Other than training a few professionals, one of the other way to tackle this problem is developing technologies for better experience in remote session. So I'm working with a couple professionals, a couple people from different professions. This is me working with an app designers. He is currently working on creating an artificial intelligence-based application for music relaxation. to be able to be used by clients and practitioners. This app will be designed to help individuals or practitioners in creating a music program consisting of Indonesian traditional music with references from their current mood, heartbeat, and the current weather. And we are also just beginning to explore the use of VR. We are planning to create a software. I'm working with lecturers from sound design, music education, and computer technology to design a software to aid music educators and music therapy in doing sessions that involve technology. Yeah, this is the final solution. Researching the use of Indonesian traditional music therapy resource in clinical setting. I could be biased in terms of this point, but I believe this is important. You want to reach out to different people from different region. You got to know their culture. You got to know the music instrument that they use. So this is, will I be able to play this? Oh, that's okay. I'll just move on. I have another video, but I believe my time is, I've passed the time, but a little bit more. So working on widening our outreach means we need to understand how musical resources is being used in different culture. This is one of my interests when it comes to research. I'm now exploring the use of gamelan for improvement of cognitive performance in healthy, in seniors with healthy aging. So we are giving them basic gamelan practice called nekep. And I provided this session twice a week for 12 sessions. We did pre-test, mid-test, and post-test, and we can see that there is improvement even in mid-test in terms of the MMSE and digit span test.
Pelan-pelan.
Yeah, so you could see that the way that we are training them to play the gamelan, you have to hit it and then you close it, you dampen it with your hand. That act alone took a while for them to be able to do that properly, but it's very stimulating because they have to divide their attention between right hand and left hand. They have to memorize which key they hit, and then they have to close it, they have to dampen it with their left hand, and meanwhile they have to also memorize patterns of the melody. So it's very cognitively stimulating, and we have seen improvement in cognitive performance. Yeah, this is my last slide. So key takeaways from this presentation. Music therapists, we got lots of work to do. And, you know, we cannot do all of that work alone. Interdisciplinary work and collaboration is a must. I'm calling out to other professionals, educators, doctors, clinicians, other therapists. Let's collaborate with music therapists to create projects, to create a better healthcare, a more holistic healthcare for your clients, your students, your patients, whatever you call it. And in order to do that, we need to respect and appreciate the traditional heritage that we have, while also embracing what might come for us in the future. So thank you so much. I'll stop my screen sharing there. That's the end of my presentation. Again, thank you for having me.
Thank you so much, Kezia. Actually, I think it was very interesting how you spoke about what you did, what were the issues you were facing, to coming up with solutions, and also looking to the future. Though we still have problems with online and virtual, we're still looking forward to the future. So I think it's very interesting how you took the disadvantages and found at least this is a way forward. And many of these actually are very true, even with the Indian context. Though we are a huge country, we still have only a small portion who are very comfortable with the internet. So that is one thing. But I would like, actually, this program that you were saying was hybrid. I think when I started my music therapy education way back in 2013, I think it was hybrid. And we were the first ones to have a 6-month complete internship in a hospital. So that was the beginning for me. But then it gave me a lot of perspective as to how to go forward, and to also understand that we do need a master's. So from your point, it was very true about having a lot of professionals who want to learn music therapy. So that's why we have a master's and we don't have a UG, because of a lot of other reasons. So the masters would have people who are already having established undergraduation or a good musical background with other disciplines if they need it. So thank you so much. And the forum is open. If anyone has any questions or thoughts, we are open and free to ask and to say. Does anyone have any questions? No?
I just saw a note from Dr. Jagdev Kumar. Thank you so much for your notes. Appreciate it.
One from Janita Karen says, thank you for the wonderful perspective. Being a music therapist in India, it was very relatable to the professional setting here in India.
Absolutely. Thank you, Janita. And I just want to take the time to appreciate what you are doing, Bhuvana, and also your colleague in India. I've heard of many wonderful work that you are doing to advocate for the work in India. We have this forum and we keep on supporting each other, and I appreciate that time that we have together.
Thank you. Yes, I think for everybody here as well, I think we connected way back in 2021 in some way, and we've been actually trying to do a lot of advocacy, try to write publications, understand. But I think from both sides, I think you're also one of the few faculty, and me and Janita being the only faculty, the workload is quite high. But I'm very happy that we can actually support each other, including Dr. Indra and all the other support that we have had. I think advocacy and awareness has been the major way forward. Yeah, and we have students now, so hopefully we'll have more later, and there may be more faculty who may build up. And one of the things that you actually said was supervision. And that was one of the major issues we also had, the support that we need when we go into clinical practice. So theoretically, it's very comfortable, 6 months or 1 year of theory. But when you actually step into that shoes of a therapist, it's very worrying, scary, and very emotional too. And I found that it is very true as a student everywhere. But for us, because we don't have enough people, it's actually very difficult. And we have to learn everything mostly ourselves. So that was also another major thing. And yes, to say, we also had a lot of discussions with our students as collaborative work, trying to understand how students from the Southeast Asian region are. So the language issues, the cultural uniqueness, which is, and what Kezia has spoken today, I think it would go mostly for the South Asian countries. We have only 2-3 countries in this region which has an education at all with less faculty. It's all of those reasons that she actually spoke was for all of us. So thank you, Kezia, and yeah, always loved the way you clearly structured things.
I just want to ask one question.
Yes, Janita.
Like how you said, ma'am, the income of students is very fluctuating here as well. I was the only one in my batch, and then we had 6-7 students, and then again 5. Then it was 1. So I see that it's the same for you. But were you able to come up with any kind of solution or idea to overcome this fluctuation in the income of students? Is there anything that we also can adapt and do for the same issue we have?
Yeah, that is a really good question. And I am so sorry, but I don't have a solid answer to answer that question, because, I feel like fluctuation in student intakes have a lot to do with cultures, has something to do with what's going on globally currently, what's the trend. Like, for example, if the trend currently is, dealing in stock markets, the young people would be attracted to that more. If the current trend, I remember that during my year of bachelor program, the trend is going to psychology major, then they will flood that major, right? It's very unpredictable. But one of the solutions that we have in Universitas Pelita Harapan and other university in Indonesia, this is actually initiated by our Ministry of Education, which is a really brilliant program. We call it Merdeka Belajar, or if I have to translate that to English, it's the freedom to learn, meaning that students from one study program is allocated a certain amount of credits to learn in other study program or other concentration or even other university. That means I can open up some music therapy courses for other students that came from, let's say, medical students, medical school, or nursing school, or the psychology, the faculty of psychology, and they can take a big chunk of the courses that are offered in music therapy. And one of the things that we did is we create an MOU with the Faculty of Psychology in Universitas Pelita Harapan, and we are planning to do that with other university to provide a specially designed curriculum for these psychology students that are interested in learning music therapy. So we allocated 20 credits out of 144, I believe, credits that all students have to take. We allocated 20 credits for them to take in music therapy. That is a really good chunk, meaning that the course will keep on running despite of the fluctuating number of student intake. And by the time they finish this exchange program, when they graduate, they will be able to take that module, hybrid module program that I designed, not from module 1, but they will have a head start. They will be able to start from module 11, let's say. So that's one of the way that we are doing things in Universitas Pelita Harapan, just to keep things running, because the fact is, university is also a business. You need money to keep running, right? So as that's also one of the other role of music therapist, especially if you are working as a lecturer and a program coordinator, you have to keep thinking about ways to keep this running, right? And collaboration is one of the answer, really.
Thank you for that answer. Actually, one thing that we had talked about here was creating some pamphlet or something and giving it to undergraduate students who are studying music right now. Because a lot of people will be interested only if they know. Here in India, most people don't even know that these kind of courses are there and such a profession is there. So one thing that we were talking about is going to these colleges which offer music courses and then talking about it to them, so that they know that okay, they have two options: they can become a musician or they can become a music therapist. So that we need to do actually. And we are also trying to, it is not like 20 credits modules, but we are trying to create single credit modules for other students like nursing students and allied health professional students. So yeah, we are also slowly trying to do it, but this is one major problem that we have, because we have all the resources, we have the infrastructure now, we have a hospital attached to the university where students can work, but students has to come. Students have to come. So this is one major issue that we have. So we are trying to cope up with it.
Yes, I like that, and I agree that how can someone be interested in something if they don't know? I totally agree to that. And constantly doing workshops and presentation can be one of the way, and also providing shadowing experience for students to be able to get a more wholesome, a more comprehensive view of how music therapists work in the field might help. And I can't say that what we are doing right now is 100% working all the time, because like I said, it's really unpredictable, but I understand the struggle.
Yeah, actually, that is a good point. You actually said showing how we work as music therapists. Mostly when we show them the kind of work we do, they're all very excited. I think in one of the awareness programs we have given to a music college was about how we worked with clients and with patients. They were really very emotional after seeing what we did. But then that's the outcome of the work that was done over a period of time. And sometimes I feel that getting through that period, you need the guidance and the support for them to get through it. So I think, yeah, all of this is very important. More students, but more time and more faculty. I hope that it will improve and it will grow. Thank you so much, Kezia. Do we have any more questions or thoughts? There's someone who's written, thanks so much for highlighting different aspects of music therapy program development. Highly appreciated. This is from Dr. Shailesh Kumar. So any other questions we have for Kezia today? Devasena ma'am, 1 second. Yeah, I'm allowing you to unmute, ma'am.
Namaste. The wonderful section. I think it's going to be helping you a lot, and in future, maybe in India also, maybe we'll be more aware of the music therapy. And so what do you think in the field of music therapy, if one learn the music and they can do better, they can learn the music therapy, they can be better music therapy, or if they don't have much the knowledge of music, the field, even though they can be a therapist, they can come as a therapy. What do you feel actually?
Can I clarify that? So, sorry, you were asking about what if these other professionals don't have music competence?
Yes.
Yeah.
If they didn't really learn music much or anything, they don't have the much of that in the music field, but still they can be a better music therapy, you think?
Well, one of the standard competencies of music therapists is good music skills. One of the modules that we provide in the hybrid module program is a specific course to prepare these non-music therapists, non-music therapy professionals to improve their musical skill. So we have 3 music therapy technique course, and the first one will be to provide them with all of this music skill, vocal skill, guitar skill, percussion skill, piano skill, and maybe other instrument skill that they masters, non-Western musical skill. We will encourage them to improve their musical skill there, and to provide them with the skill that they will be able to transfer to music therapy technique, because it's impossible to teach music therapy technique without the student knowing how to play music, how to use all this music skill for clinical purpose. That is a different challenge as well. I hope that answered your question. Thank you so much for your question.
Thank you. Also, you think whether, sorry, one more question. If you think like it should be like the music should be like a classical, you think, or like the fusions or the modern also, you think?
Oh, I've got this question a lot since I returned to Indonesia, because the perception of Indonesian when it comes to music therapy is that it's very much influenced to Mozart effect. Right? So their perspective is, oh, it has to be classical, it has to be calming music. The other day, actually, there is a news that talk about how doctors in a local hospital use rock music for their patient, and it was swarmed by people commenting on that social media that that's not right, you should have used calming music, classical music. And I just have to step in, I just have to, my educator side have to step in and commented on, what music therapy really is. But no, I don't think it has to be Western classical. In fact, I'm encouraging my students to start thinking about how they can apply Indonesian traditional music in their work.
Thank you.
Thank you for your question.
Thank you. Thank you.
Thank you, Devasena ma'am. All right. So any more questions? Okay. So if we are done with the questions here, I'd like to say thank you once again to Kezia today. And I'm very happy that we could do another session together. Probably we'll get together and do more in the future. Now we will be going to the next session. I'll be happy if you can stay in and watch along with us as well.
Thank you, Anna.
Okay, so I'm going to, I hope we have him. Hi. All right. So our second session today, so I'm going to share and introduce him for the session. Okay, I think yes. Okay. Okay, so our session today, second session for the day, is by Juan Pedro Zambonini. I hope I'm pronouncing that right. He is a board-certified music therapist from Argentina. He is completing his doctoral studies at Temple University, USA currently. He chairs the Publications Commission of the World Federation of Music Therapy. His working spaces are in the emergency department in ICU, that is with pediatric PICU, and at the Children's Hospital of Philadelphia. He is passionate about collaboration, generosity, and structural change, and hence his research interests include intervention research with at-risk children and youth that incorporates resilience theory, preventive approaches, adverse childhood experiences, psychoneuroimmunology, and community music therapy. So I am going to stop sharing, and I'm going to let Juan start his session today. Thank you so much for coming in as early as 5:30, I think.
Yes, it's
Thank you
it's
so
early
much for
here.
being here.
Yes, no worries, and it's an honor for me to be here. Thank you for having me. Would you be able to allow sharing on my part?
Yes, I'll just make you host. Yes. Yep. Now you
Okay,
can share.
let me try that. Okay. Can you see the presentation?
Yes.
Okay. Well, thank you, everybody. It's, like I said, an honor and a privilege for me to join you today. I'm calling in from so-called Philadelphia, United States. So like they said, it's quite early, but I'm hoping that we can have a nice exchange about our experience working in the emergency department of the Children's Hospital of Philadelphia. I'd like to begin by locating myself. Like they shared before, I'm a music therapist from Argentina. I'm also a male, cis, heterosexual, able-bodied immigrant with access to higher education, of middle class, of color, coming from Latin America. I'm a son, a father, a brother, and a husband, and a friend. And these things are important because they inform my ontological stance, but also my epistemological stance and the way that we do the work. This work that I'll share with you is done in a team. I am part of a large team of assistants that we provide to adolescents that are coming with psychiatric emergencies. But I bring my singularity as well. And it comes from what we could understand as a Western perspective, but has nuances between what we understand is the center of production of knowledge, like the United States, and the periphery of the production of knowledge, like is Argentina, which is a third world country, as you know. So I bring all that experience into this type of work, and I wanted to start by sharing that with you so you understand some of the constructs and positionings that might be evident in the sharing of this presentation. I also want to acknowledge that I practice in the Lenape land, which is the land of indigenous tribe, Lenape and Lenni. This is so-called Philadelphia, United States. And this is also a work that I've been doing with my manager, Amy Troiano, at the Children's Hospital of Philadelphia, but also collaborating with psychiatry, with social work, with child life, which is a profession that specializes in coping and normalizing the hospital environment for children who are admitted to the hospital, and also with pet therapy and other recreational activities that we offer at the Children's Hospital. Let's see how I do the next slide. All right, I'd like to begin by sharing with you the story of Emmanuel. This is important for us because when we are talking about adolescents with psychiatric emergencies, it's very important that we keep the focus on the people and not on the technique, not on the assistance, but on the lived experience of these people, right, that are coming to us for help. Emmanuel is a 17-year-old born and raised in West Philadelphia, which means for him that he has been exposed to a lot of things that are considered adverse childhood experiences. He has been exposed to community violence, including gun violence. He belongs to a racially marginalized group. He also belongs to the lower socioeconomic status of society, meaning that, you know, poverty brings another dimension that is also impact his physiological and his psychological well-being. He lives with 5 siblings at home, and he recently lost his cousin to gun violence. His cousin was shot. Okay, these are all composite cases that I've created to share with you as an example to protect the privacy of the patients that come see you, but this is a very common experience that we see at the emergency department here. His father is incarcerated, which is not uncommon, unfortunately, for Black males in the United States. There has been a big push towards incarceration of Black males, as you might be aware of. And he's a creative, deep thinker. He's a good friend, and he has experienced adverse childhood experiences that have increased his likelihood of suicidality by 4 times. Okay, and the adverse childhood experiences are those that I mentioned earlier, right? His exposure to community violence, having to worry where food is coming from, having experience of living as a marginalized identity in a society that is predominantly racist. So he comes to the hospital with a suicide attempt, and we see him here at the Children's Hospital of Philadelphia, which is one of the largest hospitals in the United States, leading hospital in the region. It's a hospital with 500 beds, soon to have double beds in about 5 years. They're building a new tower to receive more patients and include many floors for intensive care. And we are in the context of the pandemic and after the pandemic, where youth mental health has been declared a national emergency. And we've seen in the first 2 years of the pandemic, an increase of 31% of visits to the emergency department. There's also an increase of 315%. So it's tripled the length of stay for the patients that are staying in the emergency department, waiting to go to the next level of care. And I'll explain that a little bit more. And they're coming to what we name the EDECU, which is the Emergency Department Extended Care Unit. And they come with suicidality, namely suicide ideation, suicide attempt, homicidality, sometimes homicide ideations or attempt, and self-harm. And those are the 3 referral criteria that we have to see patients for music therapy. They are referred for music therapy when they present with these reasons. Speaking about the length of stay, the way the model of care is structured in the United States is that patients that have psychiatric emergencies will come to the emergency department to be triaged, assessed, and once there is a determination of the level of care that they need, they are transferred to the appropriate services. When we talk about level of care, we mean inpatient psychiatric hospitalization, meaning a week or more of a stay in a psychiatric hospital. Sometimes when the patient is not as acute, they can be transferred to what we call a partial program, which means that they would go to therapy sessions during the day. They would not be going to school, but they will be going to therapy sessions during school hours, and they will be sleeping at home. Or sometimes when patients are able to be stabilized enough and have the right support by the family and by services such as a psychiatrist outside of the hospital and a therapist outside of the hospital, they are able to go home with those services. So those will be the level of care, level of care that we would transfer them to after they come to the emergency department. Now, what the pandemic has brought for us is that the inpatient psychiatric hospitals, where usually these patients are transferred, are not able to receive them. They're saturated with patients. So there's long wait lists to get into those hospitals, which creates a situation in which they have to stay at the hospital to remain safe. And that's where we see them in the extended care unit at the emergency department. And that's when they receive music therapy. Their length of stay at the beginning of the pandemic was between 1 and 2 weeks in the emergency department before they could be transferred to the inpatient psychiatric hospital. That would last a week. So if you can think of the arch of hospitalization for these patients, they're probably 3 or 4 weeks out of their normal environment in this crisis situation. And we see them in the first 2 weeks. That's the context in which Emmanuel comes to us. Right? So the emergency department of the hospital has 70 beds. And like I said, they stay between a week and 2 weeks, and they receive a myriad of services that I mentioned before: child life, pet therapy, school teachers, social work, psychiatric, and there's attending physicians and nursing staff that is specialized in what the United States conceptualizes as behavioral health. I'd like to think of it as mental health. So there are numbers for you. That's what they were. Sorry, just in case it helps to see them. There's a number of evidence that has been gathered over the time and produced about music therapy to treat depression, about positive effects on well-being for adolescents and children, evidence for stabilization of patients that are coming with psychiatric emergencies. And also there's a highlight on the participants' experience to be able to improve care. And that is a shift lately where in the United States, they're considering the patient's voice more into the decisions of care. So the theory of intervention that we conceptualized when we were asked to come serve these children in the emergency department, where we needed to do focused interventions because patients are not going to be there very long. They also come in a crisis. So we need to be able to focus on the current issues while also touching on the trauma that has brought them here, right? If you think of Emmanuel, a patient that has lost a family member to gun violence, that is a traumatic event, right? And a patient that has experienced adversity like poverty and discrimination, then that's also something that needs to be healed before those symptoms can be resolved. But we cannot address those structural underlying issues in the emergency department because we don't have enough time for those things to be brought forth and healed in the right way. So what we offer is stabilization, and we rely on 2 theories that we found were important. First is the resilience theory, which is the ability, like, for all of us to be strengthened after a crisis. And then hope, which is a construct that we understand is helpful for them to feed their life drive as their death drive is so high. I also want to make a pause and say, I wanted to say this at the beginning and I forgot, but we will be talking about suicide and suicidality, and I want to acknowledge this is a very hard topic to speak about. I live it every day with my patients, but I understand also that people outside of the hospital and outside of this unit might not be as comfortable speaking about this. So I want to invite you to take care of yourself in the sense that this is mobilizing, or that you're having responses related to your life experience, that you may step away from it, take a break, or do anything you need to do to take care of yourself. Sorry, I forgot to say that at the beginning, but you please have that permission to do that as we engage in this conversation. So we're looking at resilience and hope as main theories of interventions, but also as part of our theory of person, and understanding that this is what can help youth in this difficult moment. We're also using music as a salutogenic process, which is very exciting in the frame of this event. And we are also thinking about stabilization, right? In this sense, we're addressing stress and trying to lower stress levels to help them stabilize. We're looking at mood regulation, emotional awareness, and self-expression, which is reflected on the literature cited below here, but also is something that we found in the pilot that we did when we evaluated the service after implementing it. So it was very nice to see that the literature and the results of the pilot were very consistent on these three goals for music therapy. And we are using a resource-oriented or strength-based approach using their preferred music. And this is really important because we are accessing their universe. Adolescents are hardly open to adults, right? And especially when they are depressed, especially when they're in a crisis. And when we tap into their preferred music, we're tapping into their universe. We're tapping into the culture of adolescence. We are tapping into their cultural location as well. Like Emmanuel has music preferences that are very much linked to his experience as a Black male in the United States, but also we're tapping into his emotional universe and how he expresses his feelings. We'll talk a little bit more about that when I describe the interventions, but using patient-preferred music is the big access for change. If I would come, and I heard the previous presenter talk about classical music, right? So if I would come with a classical piece, I would be creating such distance that would not allow me to enter and have a real conversation about what's happening, right? So I enter with his preferred music, and this is part of the research-oriented approach from Worldsfjord. And so these are the two theories that we are using. Like I mentioned, the 7 C's of resilience is a synthesis of the resilience theory and literature. Ginsberg and Jablo are two doctors. Ginsberg works at the Children's Hospital as well with adolescents, and they've synthesized the resilience theory with 7 components of resiliency, or the 7 C's of resiliencies, as they're called, of resilience. This 7 elements or components are coping, control, confidence, competence, connection, character, and contribution. Okay, I'll describe a little bit each one. They're pretty self-explanatory, but coping is the ability that they have to handle the stress in which they're under, right? Control is how much they feel in control of a situation. And many times for children in general, but also for adolescents that are in this in-between stage of, am I a child, am I an adult? They don't have a lot of control. And when things feel out of control, they might get overwhelmed and act impulsively with a suicide attempt. Confidence is my belief in the ability that I can do things. And competence is the actual proof of that belief, saying, yes, I can actually do things. I can do them well, okay? Connection relates to the ability to connect with others and have meaningful relationship, which is a big crisis in our society, I think worldwide, but more so in the United States, where there is such isolation and community has, the fabric of society has been impoverished so much that connection is lacking everywhere you look. And these children are looking for meaningful connection. And they might look to the internet for that, and they might engage in online interactions with strangers. And that brings about lots of issues and lots of potential. So I don't want to demonize technology. Technology is wonderful for good and also can be very bad and evil. So it's just the way that we are able to discern between how we use technology is what's making a difference for adolescents in terms of connection. I mean, we are having this conversation thanks to the internet, right? And creating knowledge and sharing. But at the same time, we could also be having superficial relationships that are not healthy. And that plays out in many things. Adolescents might come with sharing suicidal thoughts with other people and being engaged with people who are sexually inappropriate. And there's a lot of things that's happening in relation to connection for these adolescents. And we see it as they come to the emergency department. Character is the set of values and how they understand who they are. And what do I do in the face of adversity? What do I do when my peers are not accepting me? How do I take things? What do I do when I see something is wrong? And do I run away from it? Do I join it? That's part of character, is that, you know, knowing, oh, I'm a hard worker, I'm a good friend, I'm a good brother, or not. Feeling like I'm a failure, I'm disappointing my family, nobody likes me, I'm very awkward. All those things are part of character. And contribution is the ability they have to bring something to the community and say, this is what I'm here for. This is connected to purpose as well. And which is something that when we think about hope, which is the next theory I'll share in a minute, is very interesting. It's their understanding of, I can play music and I can play it for my family and it makes them happy. I can play music and I can play with my friends and we feel connected to each other, right? We use music as an example because that's my world, but they could be poetry. It could be, I like to create things. I like to create stories, or I like to build things with Legos, or well, Legos is for younger kids, but maybe I like to program things on computer, right? I like to create videos and websites and different things. Like this is my contribution, right? And some adolescents have it very clear and they know their contributions, or at least they have indications, and as they finish high school, they're able to choose a career that is aligned with that. That's the best case scenario. But there's a big bulk of other adolescents that don't have a lot of idea about what's their contribution, what are they here for? And it's developmentally expected, but also with the social crisis that we are experiencing, it's very hard for them to see, well, I don't know what my contribution is in an economy that is collapsing, in a world where, you know, environmental changes are bringing a big threat to us, where there's not a lot of faith in political systems, and they see the world collapse around them and they think, well, what do I need to go to college for? What do you want me to do as an adult? Like, the world is just crumbling around me, and their internal world therefore starts crumbling, and that's when they present to the emergency department. Hope is conceptualized by Snyder and in two ways. There's agency, which is the belief that they can get out of their current situation, and their understanding of the tools that they can use to say, okay, I have control. They're all connected to the resilience as well, right? I have control. I can do something about this. I can do something to feel better, right? And pathway is the ability to see a way out and say, I'm going to do it this way. I will start exercising. I will call my friends when I feel lonely. I will speak to my parents, and I will focus on what's good for me, right? So and I will stop doing these other things that are not good for me, right? And that's like the pathway. So all of this are things that we are thinking about as we are offering services to these patients. So as far as music therapy, we use a myriad of interventions. There's at the bottom of that slide, one that is not, it didn't fit on the slide. So if you see in the middle at the very bottom, it should say Music Improvisation by Brusha 2014, which is the first reference under music-based interventions, but just to name that. So just to go through the process, as you know, music therapy is a systematic process of intervention. So we first do an assessment, then we go to the interventions, and then at the end of the admission, we provide resources and tools for coping, or we might do that at the end of each session so they build on it. It's important to mention that we see the patients between 1 and 3 times during their admissions. So it all depends on their length of stay. So if they stay long enough, we can do 3 sessions. Usually we'd see in between 1 and 2 sessions. We first start by using song communication, which is one of the examples that I'll share later with you. In song communications, the patients are communicating unconscious material through the music and the words that are included in the music. Okay, it acts, like I explained to the patients, like an X-ray of our soul. You don't have words to describe how you feel, yet, oh, sorry. Yet what you can do is bring a song and we listen to it. And all of a sudden the song is telling your story. And you pay close attention to the lyrics and you see yourself in those lyrics. It's like, oh, I didn't realize I felt that way, but that's exactly how I feel, right? Then we also use the analogy principle by Henk Smeisters, which proposes that musical structures are analogous to psychic structures and vice versa. So psychic structures are analogous to musical structures, and this happens mostly when we are improvising, but it can also happen in songs, meaning changes in the music will be reflected in changes in their psyche, and changes in their psyche will be evidenced in the music. Okay, and so if the patient, for example, feels very isolated, and at one point in our sessions, we decide that we want to do an improvisation, and I play an instrument, the patient plays an instrument, and you see them rhythmically very disconnected, that's an evidence of the isolation that the patient is experiencing internally, right? As the therapist makes an effort to join the patient and synchronize with him in rhythm and be together, it's a psychic signal or an analogy of togetherness. And we hope that in that musical togetherness, patient is able to feel that connection that he's longing for. Does that make sense? Was that a question or just unmuted? I think it was unmuted. Oh my goodness, the slides. Okay, and another thing that we conceptualize is, or we use as for assessment, are the healthy and unhealthy uses of music. And this, it doesn't mean that some music is evil or bad. What it means is some patients use music in a very particular way, right? And some patients might use music to feed their life drive, and some patients might use music to feed their death drive. And the way that they were able to assess this in their assessment tool was if the patient feels more sad or feels more angry after listening to this music, what is the patient's experience? A couple of years ago, or maybe 20 years ago, there was this push to say heavy metal, rap, it was bad for people. Music that brought about a lot of problems. And the reality is that from our Western perspective is that the patient's experience with music is more important than what the music is bringing. It's complex. I want to acknowledge that there is something about sound, right? And dissonance. And when there is distortion in the sound, the cells in the body respond in a particular way, right? But there's also the patient's experience with that. If it's cathartic, if it's relatable, comfortable, and they feel safe in that music, then from my perspective and from my epistemological stance, that overrides the influence, the physiological influence of sound. I don't know if that makes sense, but we can explore more of that in our questions later. But the idea is that the patient's experience, there's a definition of music that says music is what happens to me when it goes through me. So it's moving away from that definition of combinations of sounds and silences, which is very, very poor definition of music. But music is what happens to me when it goes through me. And that's putting the focus on the human experience and the person's experience with music. So that's what we consider as when we are assessing. We want to see, is the patient communicating something to a song? Is the patient presenting musical structures that might be analogous to psychic structures? And what are those structures? And how can we help bring those structures closer to health, right? And is the patient using music in a healthy or unhealthy way? And how can we help them also get closer to health, right? We think health as a continuum. We don't think of, you're sick or you're healthy. You are leaning towards health, you're leaning towards illness, and we're trying to help you come towards health. And then the interventions that we use based on our assessment are lyric discussions, which is quite powerful for adolescents once we are able to establish a good therapeutic alliance and good rapport. That has to happen quickly in the emergency department. So the music therapist has to be culturally, some people talk about cultural competence in the United States. There's other people that talk about cultural humility. I like cultural humility more than competence, but yeah, the therapist, the music therapist needs to be culturally very flexible to engage with all types of patients and all walks of life as they come. So if you're able to do that quickly, because you can relax your body language, because you can use a couple of terms of their vernacular, because you are presented as non-threatening and safe, especially with those who bring trauma. And just to note on that, those who come with sexual trauma, also gender roles will play a big important part of how you build that relationship. If I have a female patient that I know has experienced sexual trauma from a male, I already know that I need to come in differently into that patient's room. And I need to find ways to modulate my masculine energy to help her feel safe. And I can expand more on that in the questions if you like, but those are different ways that a therapist can channel different energies in the room to help patients feel safe. And the other way around as well. If this was a patient who was experiencing sexual trauma from a female, then the female therapist will have to see how they handle that energy to help them feel safe. Because inevitably, when we start a therapeutic relationship, and if and when patients enter transference, then they're enacting those roles in the session. So that can happen very quickly, even before you enter the door, or that can happen over the course of many sessions if the patient is not ready to enter transference. And transference, that term comes from psychodynamic approaches, not only music therapies, but from psychology in general, and psychotherapy, to be precise. We use music-assisted relaxation, which is a very straightforward body scan with music. We use therapeutic music lessons, which are very powerful for adolescents. They bring a lot of sense of competence. They have a lot of sense of contribution as well. So I can play the song and I can play it for my friends. There's also potential for connection if they decide to play that song that they learned in music therapy with others later. So therapeutic music lessons, and it's a very non-threatening way to enter the therapy world. Some patients have never been to therapy, and some even call it, I'm in music class, or you're my music teacher when they refer to us in the hospital, because that's what they understand from school. So it's a very good non-threatening way to engage in interventions. But it is really important that the therapist makes explicit that we are working on therapeutic goals together. It is not very ethical to just trick patients into therapy and say, no, we're going to learn a song and we'll talk about your emotions a little bit. And all of a sudden we're talking about your trauma. It has to be explicit. That is a good practice, and that's something we are learning with the current research project. Patients need to understand the mechanism of change. They need to understand how this works. How is it going to help me? So that can benefit adherence of treatment later as well. When patients know why they're doing what they're doing, they are empowered. And this is also an epistemological stance. The hegemonic medical Western model says the doctor knows, the patient does, right? No questions asked, top down, right? But that is changing, and people are starting to have more agency and say, wait a minute, how does this work? Do I want to do that? Is that aligned with my values? Is it aligned with my culture? Okay, I will engage in it this way, not this other way, and allow patients to do that. But that comes from our side as professionals to be explicit. And it's a challenge because, unfortunately, some professionals don't have this very clear. They don't know the theories that they're working with or the interventions and the goals that they're working towards. So that starts there. And then in the middle, there's a power play where the therapist decides to hide that and make it not explicit for the patient and to hold power, basically, right? So, because I determine the goals, I determine your progress, and I report your progress. But if you shift that power balance, right, and then you bring that to the patient, treatment is much more fruitful and is also ethical and humanizing, which is the most important part, right? And please excuse me, I'm part of this culture right now in the United States is very outcome oriented and product oriented, part of the capitalist environment that we exist in. So sometimes I forget that the most important part is the person, like I said at the beginning, right? And this is very easy to forget in a large hospital like the one we work in. But we constantly, from the creative arts therapy department, bring that humanity back to the team and say, listen to the music that he created. Just yesterday, I had a patient that was being characterized by the team as very difficult and just disrespectful and probably aggressive towards his mother and just a horrible person. And I go in session, we spend a whole hour talking, and he writes a song about how he was abused when he was 9 years old and how he felt not protected by his mother at that time. And, I share this song with the team and everybody takes a step back, says, wow, we didn't know this about him. Right? So patient is finding a new way of being in the music. And us as professionals are able to bring a humanizing perspective to a team that might be just thinking about outcomes and might be, without knowing, classifying patients with biased personal experiences. Oh, I cannot take disrespect from these children. They need to be respectful. And you look closer and realize, well, this child is disrespectful because he's hurting. He has been hurting for the past 8 years, right? He was 9, now he's 17, and he has not had what we understand is an emotionally available adult to share this with, right? And this is when we come in and we offer a reparative experience. Oh, this flows very nicely because songwriting is the last point here in this slide. Improvisation is under that. We can't see it. Thanks, PowerPoint. But songwriting. So this patient is able to express, name things, and that starts the healing process. First step, right? Let's talk about it. Let me share it, and let me have a space where there is an emotionally available adult to witness this, to hold space for it, so that I can stop feeling like I'm not protected, so I can stop feeling like my body has no worth, my life has no purpose, so I might as well just not be here anymore. And I can start getting closer towards health and feeding my life drive. Those are part of the interventions that we used. And then as far as resources, we create playlists for mood regulation and always with patient preferred music, okay? especially for adolescents, because we understand, like I explained earlier, developmentally, they are trying to figure out their identity and the place in the world. So if I, as an adult, come with some sort of imposed structure and say, this is the music you listen to relax, and you cannot listen to anything else other than this, the adolescents will instantly reject that, and that will not bring about any health for them, right? So with their preferred music, we do playlists. We also examine it on the light of healthy and unhealthy uses of music, that playlist, and we say, okay, is this song feeding your life drive? Is it feeding your death drive? And discerning together in a gentle guidance, right? Honoring their preference, honoring their story, but also providing guidance saying, you know, I think that this song is, and letting them come to that conclusion, not even I think saying it, but just saying, how do you think the song is working for you? Is it feeding life drive or death drive? And usually we conceptualize it in simpler terms for them. We say, is this a life song or a death song? They can quickly grasp that and say, yeah, this is a death song. Hey, let's not include it. Let's include it. And I don't want you to think that life songs are, I'm happy, you know, Pharrell Williams, pop your hands. No, that is not necessarily, it could be a life drive song, right? Life drive songs are songs that they engage with and they feel more connected to others. They feel more connected to their self-worth. They feel that their story is being told. So the song might be saying, I am all alone and nobody understands me. And I'm ready to jump off a bridge. And you're like, from outside of music therapy, you might think, ooh, this is dangerous. The patient is listening to unhealthy music. The reality is that the patient is expressing something that they cannot express with words in a safe container, in a socially acceptable container, which is music and song. And so that expression, in Spanish, we say obeys. I don't know if that translates into English, but that expression is linked to their life drive and not so much to their death drive. So you see, it's a very nuanced and skilled. This is why we have to train in music therapy to be able to discern these things as therapists and say, is this a life song or a death song? Because if I were to give the patient all songs that talk about happy and sunshine, that will be harmful, right? I will be denying their suffering. I will be creating distance, and I will be masking symptoms, like you can with physiological symptoms. You can mask them and not address the cause, right? So we have to be very careful on how we use music in that sense, and this is why my credential trained music therapist, which is something that you guys were talking about earlier, so is necessary. We do recordings of original songs, so patients create their songs, we record them. Thankfully, we have all kinds of resources at the hospital. We have laptop computers that we carry in our carts into the patient's room with the microphones and the interface and all the technology for us to record a song right in the patient's room. And we were able to do that. And those songs are later exported and shared with the patient or even their family, which is a very interesting instance of connection and communication for them. Some of them say, can you send this to my mother? Can you send this to my sister? And we are opening channels of communication in the family as we do those things. Or can you send it to me and I'll share with my friends? Or can I upload this to YouTube? Oh, absolutely. It's your music, right? And all of a sudden they're sharing, right? And they're expressing. There's recommendations for music education. You should take piano lessons. You're really good at this. You know, it might be good for you. Or join a band, join the choir, right? Or connection with local resources like organizations that have like music camps or music therapists in the community that we refer to if they are interested in trying to continue their process after their admission at the hospital. So all of this is a long explanation. I hope I haven't bored you by now of how we work. And we are mapping the theories of hope and resilience to all of these interventions. And I hope you can hear those connections as we explain, as I explain. I say we because we are a team. I'm just here representing our team. All right. What else do we have? Ooh, this is a beautiful quote by Ken Brusha that talks about songs, and this is to introduce the examples that I share with you now. Brusha conceptualized the song this way. He says, songs are the way that human beings explore emotion. They express who we are and how we feel. They bring us closer to others. They keep us company when we are alone. They articulate our beliefs and values. As a year passed, songs bear witness to our lives. They allow us to relive the past, to examine the present, and to voice our dreams for the future. Songs weave tales of joys and sorrow. They reveal our innermost secrets. They express our hopes, our disappointments, our fears, and our triumphs. They are our musical diaries, our life stories. They're the sounds of our personal development. And this is how we understand songs in the context of the work we are doing with the adolescents in the emergency department. So let's share a little bit now about Emmanuel and his process. So I've explained his background to you. So he comes in session and I say, so tell me a little bit more about why you're here. And he says, I don't want to talk about it. I said, that's okay. What would you like to listen to? And he brings this song. Technology, please don't fail us. Can you hear it well? No? Let's see. Okay, just one moment. I need to sharing the sound. I just realized I didn't do that. Let's try that again.
Lately I think I'm invisible. I don't know where to begin. I'm walking through walls, they seem so paper thin. Everyone's walking right past me, like I don't even exist. If I were a home, they'd build right over it. Can you hear me when I speak? 'Cause this silence leaves me weak. It's like you never knew me at all. Can you feel me when I'm near? When I whisper in your ear? Do you hear me singing this song? I lost my own shadow. Where did it go? Now I don't know how to live in this world. I lost my own shadow. Now who can I be? 'Cause I'm not no human. If you see right through me, if you see right through sitting in.
So we hear that song, and it's quite obvious what's happening, right? We listen for connection. We listen for contribution. We listen for character and identity. And we're looking at a very blocked pathway forth, right? So we start engaging in conversation and we start creating things together as a way to feel connected. And we start having a conversation. And I am making sure that I am an emotionally available adult who is unconditionally supporting him and making space for him, right? And this becomes a reparative experience, hopefully, right? So this is one way where we use song communication to assess, right? Patient does not tell me anything. He doesn't want to engage in a conversation. I just say, well, what do you want to listen to? And boom, we have all this information, right? And then we start working towards it. First question is this you in this song? Do you ever feel like this? Yes. Okay, Let's talk about it. And then we start. Yeah. Another example. Whoop, this always happens. It's Tori. Tori is 17 years old. She was born and raised in the suburbs of Philadelphia. So that's a very different socioeconomic reality. You know, we are looking at upper middle class. She lives with 2 siblings and parents at home. She has experienced sexual abuse when she was 12. Her friends shared with her their own suicidality and depression. So she has a group of friends that are also struggling with mental health. And she's applying for colleges and cannot find strength to submit applications. Okay. Her family is very academically driven, right? And so this is a big stressor in her life at the moment. She's a committed friend. She's creative and very, very intelligent. And so we have our first 2 sessions, and similarly, like we did with Emmanuel, we explore themes of where are things and what are her coordinates for her suffering. And we realize that it has to do a lot with self-worth and a lot with the feeling that she's disappointing her family, right? Or that if she fails, she will disappoint her family, right? And this is why she feels like the only way out of the situation will be to die, right? Because there is not a really clear path forward, as we said before, thinking about our hope theory, right? But after 3 sessions of making music, I say, well, hi, Tori. Good morning. What do you want to listen to today? And she brings this song, which is very interesting. I want you to listen for here in this song for competence. I want you to listen for control. I want you to listen for connection, and listen for agency and pathway as well as we engage in the lyrics. Let me see if this is the right one. Oh my goodness. Okay. I need to go back. It's amazing how these things never go smoothly. We planned it, practiced it with Janita yesterday, everything. It's still not working. Okay, please bear with me.
I don't need validation to tell me who I am. I have lived the situation, and I've learned to understand there's no such thing as limitations. I exceed expectations. I have learned to love me. Oh, I'm free, I'm human, but I'm comfortable with me. I'm capable, got everything that I need. I'm focusing and living out my dreams. I feel my family, their love surrounding me. There's nothing in this world I'd rather be than me. I'm free.
Okay. Okay, so this is not a place she has arrived yet. I don't want to present the false hope that, oh, she's healed and music therapy in 3 sessions has, got rid of all your suicidality and now you feel free and connected to your life. But it is an indication of her standing more on health than illness and going closer to well-being and an aspiration and an expression of life drive saying, I want to go there. Right? And we talk about it and we think, what are things that would help you be free? Where do you see your family and your friends supporting you? What moments in your life can you identify where you felt in charge of your life, right? And if you were to imagine that, what would it look like? And this future-oriented thinking is far from suicidality, right? I want to stay here. I want to live, I want to be happy, I want to be fulfilled. And so this is for me as a music therapist, indication that she is healing and she's getting closer and she's already stable, right? She's not as Emmanuel, like he presenting crisis, right? This is an indication of stability, of well-being. So I communicate to the team saying, Tori brought this to session. This might look like she's getting ready to go home. So the team engages on a different conversation with the family and say, maybe Tori doesn't need to go to the inpatient psychiatric hospital. Maybe we can continue with outpatient therapy. They safety plan, social work does what we call a safety plan here, which is a very detailed list of actions that they will do in case she enters another crisis and who she's going to call and how she's going to cope. And then she's discharged home. So that's another example of how you can use music to help them stabilize and then they can move on to their next step in the journey. We have 8 minutes, is that correct? Okay, I have a lot more to share with you. I'll breeze through it. We did a pilot study, which was very successful. The slides will be available to you later, so you can read them in detail. This pilot study has led now to a feasibility study that we are doing to establish the feasibility of this protocol for adolescents with psychiatric emergencies. And hopefully the next step will be to do a full-fledged randomized control trial so that we can share the effects of this with other services and hopefully contribute to the wider community, and they can either reproduce this model or use it as a reference for their own new model. In the results, we find high statistical significance for stress reduction. We used the visual analog scale, which are self-reported measures for stress, for the construct of stress. And the construct of stress is very important because that is the piece that connects the mind and body. This is the psychoneuroimmunology part. We spent many months with my manager, Amy, trying to understand what is it that we're going to measure to understand the effects of this protocol. And we thought, well, is it agency? Is it control? Is it stability? But what stability and how? And we came up with stress. Stress was a validated construct for the visual analog scale. And we thought, yes, because through the HPA axis in the brain, stress is the piece that is allowing us to enter the connection between their emotions and the physical body. In the emergency department, we cannot have a lot of physiological effects, right? If we're thinking about vibroacoustic approaches, for example, in music therapy, right? And physiological effects. That is not the type of work that we can do in the emergency department with adolescents. It would take a big leap of translation for it to be acceptable to the culture of adolescents and also acceptable to the culture of the unit. So we thought it was more appropriate to offer this protocol. And by impacting the emotions and lowering stress, we're improving their physiological and psychological well-being, right? And so this is what the feasibility study is looking at right now. We are now, instead of just measuring stress, we're measuring stress through the visual analog scale, but also we're measuring heart rate variability as a biomarker for stress. And then we're also assessing for hope and resilience using scales, validated measures for hope and validated measures for resilience, particularly for the 7 C's of resilience that we shared, and the 2 components of hope, pathway and agency. So that's the current study that we are doing. This is a previous study, the pilot that has been already published, so I can share with you. They shared mood descriptors at the end of sessions, saying 3 words describing how you feel. They wrote it on a piece of paper. And so we see that they were from, feeling tired to feeling more excited, or from nervous to feeling more calm. So we did a thematic analysis on that, and we came up with these themes. The first theme is engagement. The second one is emotional awareness. The other one is mood regulation, which is what I was sharing with you guys earlier. That is, also documented in the literature, but it's nice to see it as evidence after the work that we've done as well. And from the patient's words, right? This is the patient's experience. This is what they're reporting after having music therapy. And also we asked them a quick question of, tell me about your experience of music therapy. How was it like writing a song together? How was it like listening to music and talking about it? And we found that it was fun and engageable and engaging and enjoyable and pleasant and calming, which at the beginning, as a researcher, I was like, oh, fun. That's, that is not a very rigorous construct. But if you think about an adolescent that has just tried to end their life and they're having fun, and what enjoyment and playfulness and fun mean, right, for their life drive, it's a quite significant finding, right, and a big contribution to their well-being. It is not a superficial thing as we could initially think, as I did when I was like, oh, okay, fun, sure, we're not here to entertain you. But in a way, fun is engaging their life drive. So it's quite an important thing. And they're engaged. So if they were withdrawn before and they didn't speak to anybody in the team for 4 days, and all of a sudden after music therapy, they're engaged and they want to go to group, they want to speak to the psychiatrist, they want to safety plan with the social worker, there's also a contribution of music therapy to the team, right? And they're enjoying it. And it's pleasant and calming, so which goes in line with mood regulation, right? It's a non-threatening and not burdensome intervention for them, right? It's easy for them to do. It's non-invasive. I'm not asking them to do anything that will cause more suffering, right? So that is also findings from the pilot. And I'd like to just finish by sharing this image, which when they talk about these adolescents and we think about their adverse childhood experiences and their suicidality and the mental health crisis that they described at the beginning of this presentation, there's a music therapist from Australia, Elise Klein, who had a wonderful critique of the resiliency theory. And the critique was that resilience places all the responsibility on the individual. You are to be resilient. You are to experience adversity and be strengthened by it, because that is the healthy expectation for all of us. But what about the system that is creating the adversity? What about all the things that I mentioned in the patient's background that are causing this suffering? Are we going to address that? Are we going to address poverty, incarceration of Black males, discrimination, health disparities? Are we sexual abuse, addictions? Are we going to address those things that are causing our children to suffer? Or are we just going to say this child needs to be more resilient, right? And yes, in the emergency department, we do what we can, but in a way that's taking water out of a sinking ship. If we don't, as a society, think that we need to start working together to fix that and provide contexts that are conducive to healing and thriving and flourishing of our children, right? So this is a good image that can communicate that critique. Oh, this koala has a mental health problem. Well, no wonder. Look at the trees around him. So my aspiration with this work is to share with you the possibilities for music therapists, for all of the healthcare professionals working in a team, for community musicians, for music teachers, for healing practitioners, to create an environment that looks more like this than the previous one, where our roots are interconnected, where our trees touch at the top and create a safe guard for our children, and they help them thrive. Thank you so much.
you so much. That was a really nice presentation. I think I learned a lot out of it. But I was pleasantly surprised at the word of salutogenic focus and music being a part of it, because we in our university we have adopted salutogenic focus. And so understanding the sense of coherence, being able to understand what we're going through, what we need, so that you can express yourself, then you know what you want, and then to take it forward. And music can play such an integral role in doing that. And I was, yes, yeah, I'm sorry.
No. I was just agreeing with you.
Okay, all right, yeah. So I really liked it, like these settings that you did, the population that you were working with, what are their needs, what we do as music therapists, and how do we bring out the outcomes. I think it was quite a beautiful flow, and the songs were really good. Actually gave me goosebumps. And yeah, if we had more time, I'd probably also be able to say there were some instances in the times that I have worked with a couple of them. And though in our hospital the dynamics are so much that we do not get to work with them for more than a few days. Yes. But the few instances I think I could really relate. So thank you so much. So the forum is open for questions. I think we can go another 5-10 minutes if anyone has questions.
I'd like to say something.
Yes.
Thank you, Juan, for the wonderful presentation, and thank you for the wonderful work that you're doing itself, because we have conversed a lot with the publications. I knew that you do something with emergency situation and adolescents, but getting to know what you actually do was really mind-blowing for me. And I really agree with the point you said at the last about the critique about resilience. Is really true. We tell children to be strong and try to face things, but what about teaching children not to become abusers, or teaching children to be polite to other people and not behave badly to others, so that the others are going into depression because of them? That is really important. And I think as therapists, we should nurture that to parents and teachers and ask them to teach this part as well. Just try to raise children in such a way that they become polite people and good people as a whole, and not behave badly to other human beings. Thank you.
Yes. Thank you, Janita. It's an honor. And I think that this plays a responsibility on us, the adults, right? And so the work that we can do to support the adult population is very important, right, in this case, because as we become better people, then our children will be healthier, right? It is also not only the emphasis on teaching them to be good people, but showing them with our lived experience, preaching, leading by example, but saying, because unfortunately, in many households, there are parents who don't respect their children, and they are parents who they are under such stress and under such difficult circumstances. I'm thinking of mothers that have to work very long hours, that, parents who are suffering from an addiction and don't know how to stay and raise a family. All these things are affecting the children. So instead of focusing on children needing to be more resilient, I think it's better to focus on adults being better people and us creating a more fruitful environment for them. And in the meantime, we will continue to work towards healing for them, right? This is why we choose these professions. This is why we engage in healing practices. But there is that part. There's a question about how instrumental music internationally can help work to curb stress, boost morale, and restore healthy life for youth. Thank you for that, Dr. Kumar. Or Yagadev Kumar, I don't know if I pronounced that right, sorry. It's coming from classical instrumental music?
Yeah, Hindustani classical instrumental music. So Dr. Jagdev is actually an Hindustani classical musician and a teacher. So he's asking that he understands the 7 C's resilience pattern, but how do we understand the same when you use instrumental music to intentionally help with curbing stress or to improve our morale?
Yes, I think that with youth it's the big barrier that we have with youth is this like culture of adolescence. It's allowing them in, like we know as adults, I could listen to this music and understand, oh, this is so relaxing. I will start using it in my everyday practice. But for them, there's distance unless they belong to that culture, and that's culturally acceptable for them, right? So this is a humongous conversation, Dr. Kumar, but it's about local production of knowledge, and what we understand is health and illness, and how music is benefiting process of health and illness, and contextualizing it in local expression. It's known to us how you know, India has globalized health and well-being through yoga and practices of healing, right? And myself included, being born in Argentina, and my mother listening to Sri Sri Sai Baba. I don't know if you're familiar, and you know, lighting Nag Champa incense, and you know, engaging in Indian culture that way. Part of the whole New Age movement in the West that has adopted this Indian practices. But there's still that distance with the adolescents, that I think that if we're thinking about that context, maybe it would be first building a rapport and a trusting relationship. And then once they are listening to us adults, we say, by the way, there's this music that we can use for relaxation. Do you want to try it? And see how they take it. But part of the feasibility study that we're doing, the feasibility component is acceptability, and is for patients, how much do they accept that intervention as culturally sound for them, and is something that they can do? Because if not, there is no adherence to treatment afterwards, right? They might quickly discard, well, I'm not going to do the crazy Indian music. They might say that, you know? So we have to first build the relationship if the patients are not in that culture and don't value that as an acceptable way of healing, if that makes sense. I'm reading the next question.
Yeah, it's actually Kezia has just said to me, thank you for your wonderful presentation and work. I appreciate your view that this work is not just about applying skills, but about the connection that we form with clients and seeing them as whole human beings. So that's from Kezia. And Srimanta says, thank you for this engaging presentation. Then we have Tejasvi, 2 beautiful sessions by Kezia and Juan. And I got goosebumps listening to the 2 examples that you had played. We have Dr. Shailesh, great heartwarming session indeed. Practice insights are really encouraging. Thank you so much. So there's one question. In your experience, how open are people accepting that music can be used as, how open are people to accept that music can be used as therapy? I think, yeah, the openness to taking music therapy.
Yes. First question I ask when I walk in the patient's room is, have you ever done music therapy? And some of them might say yes, because they've been to another psychiatric hospital before, because, you know, unfortunately, patients continue to come back with these issues because they're not fully resolved in one admission. And so if they don't, the first thing I say is, I'm thinking I need to communicate developmentally appropriate for an adolescent and say, we use music to process your emotions and to talk about what's going on. We can listen to music, we make music, and just simple explanations like that allow people to engage in the process. Music therapy is an established service at the hospital, has been there for over 25 years. So it's part of the care team. So the team understands most of the times what music therapy is for and how we work. And we have a valued place at the table to share our perspectives. So from that team perspective, there is that acceptance, and then that translates into the patients, because the psychiatrist might say, well, we here offer music therapy. He's going to come by with a cart with lots of instruments. You can talk to him and listen to music together. So that bridge is also important, which is a strong predictor for resilience, by the way. They've done research in dialysis patients that trust in the receiving care team is one of the strongest predictors for resilience for patients. So when a psychiatrist or when a physician says, oh, we have this person that can help you this way, and you say, if they build rapport, they can transfer that trust to the next professional, saying, oh, pet therapy is going to come to you. They have a dog that you can play with, and music therapy will come and you can talk about your feelings and play music together. Or integrative health will come and you can do yoga together, or you can do other techniques. And so you're building bridges. And the same I do as a music therapist. If I gain the trust of the patient, I say, Dr. Giddings, he's a psychiatrist here. He will speak to you, and you guys will talk about medication and how it's affecting you. And he's going to do probably a gradual introduction of the medication. If you ever feel funny, or if there's something that you want to ask him, you should ask every question to him. He's there to help you. And that way, when the psychiatrist comes with a white coat, this tall man, it's less intimidating, and I can engage with him more easily. Right. So there's that part.
Janita has something to say. It says, would love to hear about the practical aspects or implications from you in future. Will be helpful to apply with psychiatric clients we meet. For example, how to channel our energy in a particular way to make the patients feel safe. Yeah, I think that's very important, because we need to know how to handle ourselves to work with them.
Yes.
Yeah. Thank you, Janita, for that. And
yes, just a quick comment on that. There was a study that was trying to see which was more effective, if psychoanalysis, psychotherapy, or cognitive behavioral therapy, and the big rivalry between the two in the West. And what was the strongest predictor for success for these patients, regardless of the therapist's orientation and background, was the therapist's self-awareness. The more self-aware that the therapist became, the better their clients or patients did. So you could choose your theoretical framework, your epistemological posture, and act from it if it's sound and you are well informed in it. But at the end of the day, self-awareness is what is going to make the difference for you as a professional. And this goes not only for music therapists, this goes for physicians, for neurologists, for surgeons, nurses, everybody. The more self-awareness, and I think this is a great forum for us to talk about this, the more self-awareness and the more personal growth that we can achieve as professionals, the better we can serve the people that we serve, and the better outcomes, excuse me again for going to outcomes, we will have, right? So yes, that's a great topic, and we'd love to engage with you in a presentation or workshop about it. It's wonderful.
So much. I think we'll have to close for the day, and thank you so much for your session, and thank you for coming in so early today. We'd love to have you sometime when the time is more comfortable. And yes, Janita, you're saying something.
Ma'am, you've unmuted. Would you like to say something?
Yoga, Devasena ma'am.
Yes.
Yes, ma'am.
Namaste, Vanakkam. So it's wonderful section, and it was great service. I saw when I hear the songs, it's really very lovely. And of course, you are making clients, the patients, that to love themselves, and easy to make, others to love. And because they have like coming the confidence for them. And yes, others also love, my family members love me, like that. Just bringing that emotionally, that even just really helping, really lovely, really wonderful. And your work really is very, very, very interesting. And when you are working with the clients, the patient, only the yoga therapy, or they are going under the medication also, just to know?
It's the whole approach. So there's integrative health that does yoga and other techniques for mind-body connection, music therapy, pet therapy, social work, child specialist, recreational therapist, psychiatry, and physicians and nursing staff as well. This is the team. And also there's safety observers, which is a very important role, which are people who are one-to-one with the patient all day. They need to observe them just to ensure safety, that they don't harm themselves or they don't attempt suicide in the hospital because they are at risk. And they build relationships with them, right? And that's a very important, they are the connectors, because they spend 12 hours with them during every day, right? And sometimes they can be there for 3 days in a row, so they build a relationship. And they are also those emotionally available adults that are offering reparative experiences. If my mother doesn't listen to me at home, but then I have a safety observer who is female, who's listening to me and who is giving me space and holding me in high regard, then that's a healing experience as well.
Yes, yes. Because even in India, people started to work, both of them going for the job, and then it's happening even in India. They used to be joint family, and of course, they used to get the love from one or other person, but it's happening even in India. So just to see your work, really, really marvelous.
Yes, thank you. Thank you.
Thank you. Thank you so much.
Yes.
Much, ma'am.
Thank you.
And thank you so much, Juan, once again. And I
Yes.
hope that we can get to listen to you some more later. So I'll take leave today and see you again next week for another last session. So thank you, everybody. Have a good day. Juan, you too have a good day. Bye.
Thank you. Bye.